I'm Dr. Shay from the OB Anesthesia team. How are you doing?
Nice to meet you. I'm Dee Dee.
Nice to meet you, Dee Dee. Congratulations.
Thank you.
Is this baby number?
Baby number 3.
Number 3?
Mhm.
Wow, that's exciting. You got a full house, huh?
Yeah.
All right, so I'm just going to kind of start from the beginning. We see everyone here in labor and delivery because, you know, like they say, you're supposed to expect the unexpected when you're expecting. I just wanted to say that part. So do you have any medical problems prior to the pregnancy?
No.
Great.
No medical problems.
Awesome. So you don't take any medicines for anything?
I take my prenatal vitamin. I take Tums for heartburn occasionally, and sometimes Tylenol just for back pain.
Great. So no high blood pressure, asthma, heartburn?
Occasional heartburn.
Okay,
I'm not having any right now, but throughout the pregnancy I've had heartburn.
Great. And have you ever had any surgeries before?
No surgeries.
Perfect. Anyone in your family have any known history of anesthetic complications or problems with anesthesia that you know of?
Not that I know of.
Great. And did you have epidurals with your prior pregnancies?
I did. For both of my pregnancies, I had an epidural. Both of them were induced.
Great. Any problems with the epidural that you remember before or after?
No, I was a little uncomfortable after a couple hours of my first one. The doctor came in, gave me more medication, and then it felt fine.
Perfect. So are you planning to have an epidural for this pregnancy?
Yes, I would love an epidural.
Great. So since this is the first time that we are seeing you, I want to go over all of the pain control options for you. We don't force anything on anyone. Of course, some people come in with birth plans and all, but we want you to be aware of all of your options. So we divide pain control into roughly 4 categories. The first one is just, you know, natural childbirth, which is breathing methods, meditation. Sometimes ladies have doulas come in, and that's perfectly fine, and that is mostly an unmedicated birth. The second option is IV fentanyl, which is a narcotic, as you may have heard. You can have up to 3 doses of IV fentanyl, and usually after that, the nurse will say it's time for an anesthesia consult. We try to avoid the IV fentanyl around the time of delivery because it can make you and the baby a little bit sleepy and drowsy, so we want you to be awake, and we want baby to be awake and vigorous. After the fentanyl, you have the option to receive nitrous oxide, which is laughing gas. You may have heard about that at the dentist. I would say it's effective for reducing a little bit of the pain, but it's more a way to deal with the pain a little bit better. And most of the time, almost at least 90% of women end up getting an epidural after they request the nitrous oxide. And then the final option, which is our gold standard, is the labor epidural, which you kind of already know about, but we'll talk a little bit more about it. We do that for most of our patients here because they end up requesting that. We have you sitting up kind of like on the bed. You can have your husband or your partner stay in the room with you, and we have you positioned in such a way that we open up the spaces in your spine. We clean off the area really well, put a sterile drape on, and numb up the area with a lidocaine, which is the numbing medicine. And then we use a bigger needle to find the right area in your spine, the epidural space. Once we're in the epidural space, then we inject a little bit of medicine there. And after that, we leave a small little catheter in there. The catheter is very, very thin tubing that stays in your back, and you don't really see it because it's taped on your back. After that, in about 5 to 15 minutes, you start to get a lot more comfortable. And after that, there's a pump here, which every 45 minutes you'll have medication delivered to your back. The medication is a dilute concentration of a numbing medicine and also a narcotic. Some common side effects of the epidural: sometimes you can have a little bit of dizziness from a drop in blood pressure. That's why we often check your blood pressure very frequently as soon as the epidural is placed. Sometimes people have a little bit of itching, which is also normal, and usually it's not very severe. And otherwise, mostly people get a little bit sleepy, drowsy, and it's a good time for them to fall asleep. There's a lot of information. Do you have any questions so far?
Yeah. What happens if it doesn't work? If the epidural doesn't work?
Doesn't work well. So we try not to leave this room until you're comfortable. That being said, 1 in 20 epidurals may require replacement. And if it doesn't work, then there are several things that we can do. We can try a stronger medication. We can troubleshoot the epidural, reposition it a little bit, and if those methods don't work, then ultimately we replace it. And it's not a bad thing to replace it because that is there's much higher likelihood that the second one will actually work. And any other questions about?
Any other risks associated with an epidural?
Yeah. So 1 in 100 to 150 women sometimes develop an unusual headache, what we call a post-dural puncture headache or spinal headache. It's very characteristic that gets a little bit worse when you stand up and gets better when you lie down. And if that happens, we can talk a little bit more about it because it's very easily treated. Other more scary things like bleeding into the spine, nerve damage, all those things are extremely rare because where we're going is far below any vital structures like the spinal cord. Typically the worst thing people experience is what we call a transient paresthesia, which you might notice like a lightning pain going down one leg, and that's just because maybe the needle brushed against a free-floating nerve and it's very benign and not harmful to you. And the risk of infection is also very, very low because we clean off the area very well with antiseptic solution, and we keep the whole procedure very sterile.
When am I eligible to get an epidural? Can I call you anytime or?
So most women typically call for the epidural when they're in active labor, meaning your cervix is dilated at least 4 or 5 centimeters and you're having regular contractions every 3 to 5 minutes. But there's never a too early or too late time for an epidural, as we would say here. We are staffed 24/7 with obstetric anesthesiologists, resident physicians, and attendings. And when you call for the epidural, within 15 minutes, someone is going to respond and come do the procedure for you. Although I typically like to cite to patients that if you're still kind of getting up and walking around, still eating solid food, and you're not in a lot of pain, then it's probably a little bit early. Because once you have the epidural, we have you on a clear liquid diet. And that's because you can get a little bit nauseous from all the pain, and also there's a small little narcotic in the epidural which can make some women nauseous. And once the epidural is in, then you're also laying in bed and you have a urinary catheter, so at that point we consider you to be in active labor. Too late, even if you're 10 centimeters dilated and if it's your first baby, most of us will put an epidural in for you. But if the baby's coming out and you just have to push a little bit, usually then we say it's probably best to just push and skip the epidural.
Okay.
That being said, most of the time we have enough time to get it in.
Okay.
Okay.
Mm-hmm.
Are there any other questions that I can answer for you?
No.
Great.
Any questions?
All right. Nice to meet you.
Nice meeting you too. I'll call you soon.